So a 67-year-old man presents to the emergency center with complaints of chest pain with radiation to the left arm and the jaw. It is a classical angina pain which we can see here. Actually, nowadays, every year you will get one clinical case. Sometimes they can ask you clinical case regarding ECG, wave and segment. He reports feeling anxious, diaphoretic and short of breath. His past history is significant for type 2 diabetes mellitus. It can be uncontrolled diabetes and dyslipidemia. So in the patient, it can be more cholesterol, it can be more cholesterol can be high, or it can be increased triglycerides, or increase LDL, or decrease HDL, whatever. So patient is having hyperlipidemia. On examination, patient appears to be in moderate distress and anxious. So when there is angina, there is always some anxiety, anxious. So his ECG shows evidence of acute myocardial injury. Clear? In the inferior leads. Now they will ask you in the exam, like the emergency room physician suspect that left anterior descending artery is involved. LADA, the widow artery. Okay, a lot of mortality happened because of this. LADA, left anterior descending artery might be involved. So they will ask you question from this clinical case. First question can be, what would the ST segment of this ECG look like? So in the case they have mentioned, there are some ST changes. Okay, so in the question they can ask, in the case of myocardial infarction, what can be the ST segment change? Second question they can ask, on which leads would you see this ST elevation segment change? And third can be, what does T wave represent? So what P wave represent, what QRS represent? So like that, they can ask you from this clinical scenario. So as we have discussed in this case, 67-year-old man has chest pain and ECG evidence showing the acute MI. So what change is very, very common? It is ST segment elevation. It is ST segment elevation, which can be because of MI. And the leads can be because it is inferior leads, lead 2, lead 3, and lead AVF. Clear? So ST segment elevation change will be elevation of ST segment. Leads can be lead 2, 3, and AVF. And T wave, T wave represent ventricular repolarization. Okay, so we know about P wave, QRS wave, and T wave. P wave is for atrial depolarization, QRS is for ventricular depolarization, T wave is for ventricular repolarization. So like that, clinical case-based scenario, they can ask you a question like this. Now, before going in more detail about this, at least we must discuss what are the wave, what are the segment, and what is the interval. So what is the basics of these terms? For example, if I make a simple P wave, QRS wave, and T wave. So already there are different types of terminology. One terminology is wave. What is wave? Second terminology is what is segment. And third terminology is what are the interval. What are the interval? So any fluctuation which you are going to see in the ECG, they are called as simply wave, like P wave. Okay, this is your P wave, QRS wave, and T wave. So any fluctuation which we can see is simply called as P wave. This fluctuation can be called as QRS, and this is called as T wave. And segment, if this is segment, what is segment? So S for segment, S for straight line. So whenever there is a straight line like this, okay, it is called as segment, like PR segment or ST segment. Okay, so any fluctuation in the ECG is called as wave. Straight line is called as segment. And what about interval, doctor? So whenever they ask you about interval, you must understand they are asking about wave plus segment. Like if they say PR interval, it simply means P wave plus PR segment. If they say QT interval, QT, PR interval and QT interval. So QRS wave, then segment, and then. So when there is a wave plus segment, it is called as interval. If there is only fluctuation, it is called as a wave. If there is a straight segment, it is called as segment. If there are combination of wave plus segment, it is called as interval. Now, P wave represents, P wave usually represents what? It represents atrial depolarization. Atrial depolarization. P wave represents atrial depolarization. QRS represents ventricular depolarization. Ventricular depolarization. And T wave, as asked in this question, what about T wave, doctor? So T wave represents mainly ventricular repolarization. Yes, Yasir, you have taken CABME course. Okay, you can message uh, in the Telegram group. I will respond to that. If you doubt, you can message me there. Okay. So P wave is for atrial depolarization, QRS is for ventricular depolarization, and T wave is for ventricular repolarization. Now, where is atrial repolarization? Why we cannot see atrial repolarization in the ECG? Yes, yes, Yasir, can you tell me why we cannot see atrial repolarization in the ECG? This is again a question asked in your exam or Viva. What is the answer? Answer is that, my dear, ventricular depolarization overlaps atrial repolarization. But ventricular depolarization is a higher event, more electrical event. So it will, you can say, hijack atrial repolarization. You cannot see that. So normally we are seeing only ventricular depolarization, not atrial repolarization. Now about the time interval. What they will ask you in the Viva. What is the time interval about this? Okay, let me see how many understand this. P wave, QRS wave, and T wave. Okay, now you will tell me. This is P wave, QRS wave, and T wave. Now, when I say segment, okay, segment, about the segment, PR segment is this segment, ST segment is this segment. Now, when they ask you about interval, PR interval is P wave plus PR segment from here to here, and this is QT interval. So PR interval and QT interval. Now about the time. So P wave is around, we can say, 0.1 second. Around 0.1 second. Okay. Actually, it is a range. In medical science, there is always range. There is never an absolute value. But just to remember, you can say 0.1 second. Otherwise, you can say 0.082, 0.12. You can make a range out of that. Again, PR segment. PR segment is again 0.1 second. Very easy to remember for your exam. So again, range will be what? 0.08 to 0.1 second. What about PR interval, my dear doctor? Answer will be 0.1 second to 0.2 second. Very easy to understand. P wave 0.1, PR segment 0.1, PR interval 0.1 to 0.2. You will never forget like this. And what about QT interval? It is around 0.4 second. So range can be around 0.36 to 0.42 second. So this is a must before your clinical viva in the MBBS. And even in the question, they can ask like that. They will give you a clinical based scenario and they will ask you what is wave, what are the segment, what are the interval, and what are they representing, and what are their time span. So all this can be understood by this single page. 0.1, 0.1, 0.1 to 0.2, and zero point 0.4. Why I'm telling you about this? Until you understand this concept, you cannot understand about the heart block. Again, a new topic for the ECG for your MBBS exam. So this much is clear. So first degree heart block. Whenever you will say first degree heart block, simply means prolongation of the time taken for action potential to propagate through the AV node. Abnormal long PR interval. So whenever PR interval is more than zero point 0.2 second, it is called as first degree heart block. Single characteristic of first degree heart block, whenever PR interval is more than 0.2 second. Because normal is what? What is the normal interval? Normal interval is 0.1 to 0.2. So normally PR interval ranging from here to here is between 0.1 to 0.2 second. I hope you will not forget that. P wave 0.1, PR segment 0.1, PR interval 0.1 to 0.2. Only if PR interval is more than 0.2 second, you will make the diagnosis of first degree heart block. First degree heart block. What about second degree heart block? In second degree heart block, there will be failure of some, but not all action potential to propagate through the AV node. I will discuss in detail, don't worry. So in second degree heart block, all wave will not pass from atria to ventricle. Suppose there are 4 waves coming from atria to ventricle, 2 will stop, only 2 will come. It is second degree heart block. Okay. In third degree heart block, it is a complete heart block, failure of all action potential to propagate through the AV node. Let me discuss one by one. So first was, for your exam, it's very important. What is first degree heart block? First degree heart block. हमने क्या डिस्कस किया रिगार्डिंग फर्स्ट डिग्री हार्ट ब्लॉक? ओनली थिंग इज दैट PR interval. This is P wave, QRS wave, and T wave. P wave, QRS wave, and T wave. So in this, PR interval should be more than 0.2 second. Only one characteristic of first degree heart block is that PR interval, not segment. PR interval should be greater than 0.2 second. This is your first degree heart block. Now about second degree heart block. In second degree heart block, there are two conditions. In second degree heart block, there are two conditions. It can be either Mobis 1, either it can be Mobis 1 or it can be Mobis 2. It can be either Mobis 1 or it can be Mobis 2. Okay. Mobis 1 has a phenomena called as Venke-Beck phenomena. Again, a short note. What is Venke-Beck phenomena? They are very easy actually, if you understand the concept. What is Venke-Beck phenomenon? Just if you see this characteristic ECG, you will understand what is Venke-Beck phenomena. This is P wave, PR interval, QRST, P wave, PR interval, QRST, P wave, PR interval, QRST, then P wave, no QRS. One more P wave, QRST, P wave, QRST. See, PR interval is short, then big, then bigger. Then after this P wave, there is no PR interval. It is called as progressive. When there is progressive increase in the, when there is progressive increase in PR interval, when there is progressive increase in PR interval until one P wave drops. One P wave drop. It is called as simply Venke-Beck phenomena. Venke-Beck phenomena. And this is characteristic of second degree heart block Mobis 1. I have told you there are two types of second degree heart block, Mobis 1 and Mobis 2. This is Mobis 1. So Mobis 1 and Mobis 2. So in first degree heart block, what we have discussed, please tell me. In first degree heart block, the only thing is that PR interval is more than 0.2 second. PR interval is more than 0.2 second. Only one thing you have to see, and if it is there, you will say diagnosis is first degree heart block. In second degree heart block, there are two different types. One is called as MOBIS 1, other is called as MOBIS 2. MOBIS 1 has a characteristic phenomena called as Venke-Beck phenomena. If there is Venke-Beck phenomena, your diagnosis will be MOBIS 1, second degree heart block. And how to see that? You can see here. Progressive increase in PR interval. PR बढ़ते 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 खत्म हो जाएगा और फिर नया PR शुरू हो जाएगा. Are you getting my point? PR keep on increasing until one P wave will drop and other PR will start. See, small PR, big PR, bigger PR. Then there is no QRS after this P. There is no QRS after this P. So progressive increase in PR interval until one P wave drop is called as Venke-Beck phenomena. Every year they will ask you this as a short note or as a clinical case. Okay, so this will be found in second degree heart block. It is MOBIS 1. Now, in other variety, that is MOBIS 2, what is there? Okay, I will discuss again. What about MOBIS 2? In MOBIS 2, there are two different variety. One is called as 2:1, other is called as 3:1. Okay, and it's very simple. If there are two P wave followed by one QRS interval, two P wave followed by one QRS interval, it is called as 2:1 MOBIS type 2. If there are three P wave, one P wave, two P wave, three P wave, and then again one QRS, one P wave, two P wave, three P wave, and then again one QRS. Okay, it is called as 3:1. So it's very simple. So one P wave will drop, other P wave will have QRS. So whatever signals are coming from atria, one will not come, other will come. One will not come, other will come. So it is called as MOBIS 2, 2:1. And if after 2 drop, 1 P will bring QRS, it is called as MOBIS 2, 3:1. So see, it's very, very simple. We should not fear this ECG and heart block. It's very important for your exam. So once again, my dear doctor, what you will see in first degree heart block? In first degree heart block, PR interval is more than 0.2 second. Okay, it's very simple to understand. PR interval more than 0.2 second. Only this much is sufficient to make the diagnosis. Okay, so 0.2 second. If it is more than 0.2 second, it is first degree heart block. In second degree heart block, there are two variety for your exam. One is MOBIS 1, other is MOBIS 2. In which MOBIS you will get Venke-Beck phenomena? Answer is MOBIS 1, not MOBIS 2. In MOBIS 2, there are two variety, 2:1 and 3:1. 2:1 and 3:1. Now in MOBIS 1, Venke-Beck phenomena, what is the definition by which you can say this phenomena is Venke-Beck? And it is a characteristic of MOBIS 1. Answer is progressive increase in PR interval until one P wave drops. One P wave not followed by QRS. See, this P wave is not followed by QRS. One more P will come. So there is a pattern in the drop. There is a pattern in MOBIS 1 and there is a pattern in MOBIS 2. In MOBIS 1, there is a progressive decline. In MOBIS 2, there is a characteristic. One drop. For example, you have to meet someone. You have to go on your date. On the first date, on the first meet, you are 5-minute delay. On the other meet, you are 15-minute delay. On the third meet, you are 30-minute delay. On the fourth meet, you are not there. Again, you will say sorry. And again, 5-minute delay, 15-minute delay, 30-minute delay, again absent. It is called as Venke-Beck phenomena. Second degree heart block. In 2:1, 3:1, there's a pattern. What is the pattern? That this is confirmed. On one date, you will be absent. On other date, you will come. In 3 to 1, on 2 dates you will be absent, on third date you will come. There's a pattern. So when there is a progressive pattern, 5 minutes, 15 minutes, 30 minutes, then absent, it is called as Venke-Beck phenomena. Is this clear? जब पीआर बढ़ते बढ़ते खत्म हो जाए और नया पीआर शुरू हो जाए, when PR interval keep on increasing until one P wave drops, it is called as Venke-Beck phenomena. See, in MBBS, purpose should be you must understand and learn also. There is no time to revise. So in the class itself, try to understand also and try to remember also. So I hope now you will not forget about the first degree, second degree, and third degree. Clear? Okay. So this is about second degree, 2:1, MOBIS 2, 3:1, MOBIS 2. So MOBIS 1 is Venkebeck, and this is now about third degree hard block. What about third degree hard block? In third degree hard block, I have told you there is no association between atrium and ventricle. No signal is coming from atrium and ventricle. Both are living together, but they are not together. Okay. So although they look as if they are together, you will think that both are together. But atrium is dancing its own rhythm and ventricle is dancing at its own rhythm. There is no correlation between atrium and ventricle. So ventricular rate will become very, very less. Heart rate will become very, very less. And sometimes in the third degree heart block, if heart rate become even less than 30, okay, no blood will go to the brain and we will have syncope. No blood will go to the brain and we will have syncope. And that syncope is called as, again, one more short note for your exam, Stokes-Adams syndrome. So Stokes-Adams syndrome is found in first degree heart block, second degree heart block, or third degree heart block. Tell me, answer is third degree heart block. Stokes-Adams syndrome मतलब क्या? Syncope due to bradycardia. Syncope due to bradycardia. See, already all lectures are available in the, if you go to DocTutorials MBBS curriculum videos, curriculum wise, every lectures are there in 3D form, animation and all. Even then, we are trying to come live every Tuesday so that whatever doubt you have or some clinical case for the exam, so we will try to just revise those topics. So they are very, very high yield. It means they have to come in the exam. They are such an important topic. You cannot miss these topics for your exam. Exam में आना ही आना है, somehow or the other. They will ask you MI feature. They can ask you ST elevation. They can ask you hard block, first degree, second degree, third degree. So in 30-minute span, we will discuss a lot of things. So Stokes-Adams syndrome is a characteristic of which hard block, first degree, second degree, third degree. Because there is a bradycardia. And when bradycardia is causing syncope, it is your Stokes-Adams syndrome. So Stokes-Adams syndrome is characteristic of third degree heart block. So I hope I have clear about that. We have a clear idea about this. Okay, now about the leads. Lead 1, lead 2, lead 3, lead AVL, AVR, AVF. What is lead 1? Lead 1. Lead 1 is when, suppose this is your left arm, this is your right arm, and this is your left foot. You can see here in this diagram, lead 1 is between left arm and right arm. It is between left arm and right arm, isn't it? And lead 2 is between right arm and left foot. Lead 3 is between left arm and left foot. Clear? Lead 1, lead 2, lead 3. It's very easy. What about AVL? AVL is actually VL only from the left arm, but you have to augment. You have to augment because if you are taking individual voltage, it will be very, very less. So it is called as AVL. So negative lead will be on the left arm, sorry, positive lead, and other will be on the foot. Other will be on the ground. So grounding is done. So this is AVL, this is AVR from the right hand, and this is AVF from the foot. So VF is what? Voltage of the foot, right side. This is the left side, but they all are augmented. They all are augmented. Then we have six chest lead, V1 to V6. They are six chest lead. So this is the 12 lead placement. We know about that. Now a bit about this question. Choose one of these answers for the question 10.1 through 10.3. P wave peer interval. Okay, tell me. Period. This is your question. Period when ventricular action potential are in their plateau phase. In the plateau phase, do you remember the diagram? If you remember this, okay. If you don't, I have to draw this diagram for you. This is diagram of your atrium and ventricular action potential. This is called as phase 0, phase 1, phase 2, phase 3, phase 4. Phase 0 is actually called as depolarization. Depolarization. Phase 1 is early repolarization. Phase 2 is plateau phase. Phase 3 is late repolarization. And phase 4 is simply called as maintenance of RMP. Maintenance of RMP. We have discussed in detail in the videos, but I am giving you how to write in your examination. Okay. So depolarization is due to influx of which ion? Answer is sodium ion. Answer is sodium ion. Okay. So phase 0 or depolarization is due to influx of which ion? Sodium ion. And it's very easy to understand. Phase 1, phase 2, and phase 3 all are due to outflux of potassium ion. But why we will get plateau? Because in the plateau, there is also influx of calcium. So that will form a plateau. And phase 4 is simply maintenance of RMP with the help of sodium potassium pump. Now come back to the question. Period when ventricular action potential are in the plateau phase. See, in the plateau phase, how can you link with the ECG? P wave, QRS wave. Yes, anyone tell me. This is P wave, QRS wave, and T wave. Is there any idea? Anyone? Period when ventricular action potential and the plateau phase. Anyone? It is between depolarization and repolarization. Prolonged during first degree heart block. What is prolonged during first degree heart block? We have discussed. PR interval should be more than 0.2 second. 0.2 second. Third, produced by depolarization of atrial fiber. Again, answer will be what? P wave. P wave is due to atrial depolarization. So this is it for today's discussion. I will not prolong the session. Already it is 6:40. Okay. And please, for any doubt you have, there is a Telegram group of DocTutorials. You can tag me the message and I will try to answer that. And every Tuesday, I will try to bring one more topic continuously for your exam before your Prof exam. Is this clear? So this is it for, if you have any doubt, you can ask me.